Good morning for the Swedish people, ladies and gentlemen, and good afternoon for the Indian people who are participating in this webinar. We have the series of webinar we have started, and today the first one on improving quality of the healthcare at a hospital. My name is Dr. V.K. Singh, and I'm from medical background. I'm the managing director of InnovatioCuris. This, in fact, today's webinar was supposed to be conducted by Sachin, but he got it indisposed. So I am doing the thing for the webinar today. The InnovatioCuris is a knowledge platform which is 3 years old, which has two bodies: for-profit, not-for-profit. Conference on 5th and 6th October is Swedish. Participating in it. We are having a complimentary webinar, which is the series with the Swedish companies, so they understand what is the problem of Indian scenario and what they can really bring on the table to the India. We also have Innovators Club, which is also to see young innovator how to go about it. Also, we are in one of the state incubator where health domain we are looking after, that in Gujarat. Well, we also have cyber security. We are going to roll it out in the month of September for the health people. Ministry of Defense, we are already doing it for 2 days to 4 days program. So this is what it is. And Swedish is very close to us. I was personally involved in SIDA program of the Sweden government, and ultimately now we are taking the series so that companies can start talking, know about us, and also they know the Indian scenario. Well, I would take my privilege to introduce the Josa Kare, Counselor and Head of Economic Section, who is responsible for trade promotion and economic affairs, trade policy matters, as well as promoting Sweden and cultural affairs. She also handles high-level visits within the scope of trade and economy. Well, India and Sweden, the Prime Minister had gone there and they have signed it up. We are at the middle and at the lower level to execute the wishes of those two countries so that we can take forward. I hand over to the Josa to just tell us something about on the Swedish Sea. Thank you. Josa?
I cannot see Josa here. She's not logged in.
Not logged in. Is Kika? She's not logged in. Well, I think there is something must have happened. She has not come on the scene. If she comes later, we'll still like to that she tells us something that what are the, because she wanted to refer at the government to government level, what is the expectation and how we can take it forward. So we will do that. In the meantime, I would let me introduce the Ms. Champa. She is the one who is in charge of the Swecare, and this is the organization that we have gone to Sweden and signed up as our partner for this. Shimpa is the founding member of the Indian healthcare startup. I have met her too, of Track My Beat, dedicated to reducing the global chronic disease burden. Currently at Swecare Foundation, she is devoted to identify collaborative opportunities and forging sustainable partnership. The whole idea, our mission is even our organization, how to optimize healthcare delivery costs at the last mile and yet keep the quality. Over to Shampa, if she can tell us something about the Swecare. She was there?
I'm here. Sorry, it took me a little bit to unmute myself. Thank you for the introduction. I can hear you. Can you hear me now?
Yeah, we can hear you.
Good. Yosa had said that she was signed on about 5-10 minutes ago. So if you could just check with her while I do my introduction, because she might be in on the wrong webinar ID, possibly. Thank you for the introduction, Dr. Singh. I am, as you said, representing Swecare Foundation, and we are co-organizing these webinars. We have been working with InnovatioCuris and Sachin in particular over the last year or so in an EU-funded project to bring smaller companies to new markets, and India was such a market. And I must say our cooperation has been exceptional. And so thank you for that. Swecare Foundation is a semi-governmental foundation. We're funded by the Ministry of Health for the large part, and some of our funding comes from member organizations and companies, of which we have about 100. We are really just a nodal point to connect different actors to one another to ensure that we can do business together. That's basically it. So if you need any help on the Swedish side, we're the people to contact. Thank you.
Josa is back. Josa is not back now.
Josa, you're already now in, I suppose. I had already introduced you.
Yes, good afternoon.
Yeah, I've already introduced you to the people, and I would request you that what the government of India and Sweden, the prime ministers have gone and signed, that what you really have something for us at the level of the high level, while we are executing various things at the lower level. For the Joseph, please. Yeah.
Well, thank you and good afternoon, everyone. Can you hear me?
Yes, we can hear you.
Yeah.
Excellent, excellent. Well, thank you first to the organizers, to InnovatioCuris, and to you, Dr. Singh, and to Sachin Gaur for inviting me to this webinar. I would like to start by congratulating InnovatioCuris and Swecare for entering into this MOU and arranging this first event under your collaboration. As you're very well aware, Sweden and India share a long-term bilateral relations in many sectors of mutual interest. And this year we were very happy to receive the Honorable Prime Minister, Mr. Modi, to Sweden. And we've seen some key outcomes of that, including the signing of a joint action plan and the launch of a joint innovation partnership. Within these, and also within our previous ongoing collaboration within the India-Sweden Joint Commission, health and life science are an important area of our collaboration. And with an active MOU in this area since 2009, we are very fortunate that in next year that this collaboration will complete 10 years. And I think we see a number of public agencies and also private sector actors from both sides developing key collaborations within this area. I think developments in India are extremely interesting at this point in time. We are witnessing a large shift in the composition of the health burden of India, and there, of course, from communicable to non-communicable disease. This is a process that Sweden also has gone through. And it's a global problem that requires international cooperation to handle the local implications of it. Also, I mean, we're in a position to congratulate India on the newly announced flagship health insurance scheme that the Honorable Prime Minister has recently unveiled. And such a publicly funded medical treatment is, of course, a step in the right direction, even if I am sure that the weeks and months to come will also show how the implementation process of this is to be rolled out. Quality private healthcare is one, I mean, key availability, but in remote areas it can look very different. And I think that's also something that we in Sweden can relate to, even if our scale is very different, of course. Many other issues are similar between us, so costs related to diagnostic tests and medical follow-ups, etc., and costs beyond the hospitalization expenses. But a well-implemented rollout, with that, this can be a real game changer. And I think if you go to Sweden instead, the healthcare costs have been increasing continuously, and Sweden is spending a relatively large proportion of GDP on healthcare, which in Sweden is largely tax funded in a system that ensures equal access to healthcare service. This is a cornerstone of the Swedish welfare state and widely supported. And the responsibility for health and medical care in Sweden is shared by the central government, the county councils, and the municipalities. I think the system that we use with a unique personal identity number has enabled also the digitization of health services and provides data for ongoing patient care, into use of drugs, compliance with prescribed treatment, and follow-up of outcomes on a large population scale in our context. With this, I think that national e-health and digitalization is one of the things where we can also share many experiences that we have made, and it has also enabled much of that healthcare-based innovation, together with our technology-driven environment, that can pave the way for future collaborations between smaller private sector actors, innovation companies, and startups between Sweden and India. Many Swedish medtech innovations have become global standard, and we see some interesting new companies also within this area. So the medtech are represented across the whole spectrum of the industry today. We can mention radiotherapy and imaging, especially interesting ones. And digital solutions come into play very, very closely here. With that, I would like to conclude. I mean, that these are several challenges and problems that also must be addressed in the Swedish context, but we look forward very much to the India-Sweden collaboration. And with the Swedish commitment also to the SDGs and an integrated approach where health becomes a key part of that. And I think what we can see, academia, private sector, and government agencies doing together with these issues also in Sweden, or in the Sweden-India collaboration. I think this new collaboration between Swecare and InnoHealth is an extremely interesting one, and I wish to congratulate you and wish you the best for this webinar and for this continued collaboration. Thank you so much.
And the opportunities what both countries have for each other, so that we can optimize and bring it on ground. I assure you that we don't use, but we want to translate it on the ground, and your help, being a local in India and embassy, would be a great help, and we shall be meeting, exchanging notes, and telling the progress that how we are going to do it and how you want us to do. So grateful to you for this. Viewers, you have already know that it is improving quality of care of hospital. You have heard Josa's views about India, Sweden. You have heard about me, what our organization and how it is linked up with them, and how we want to take it forward. After that, the IC InnovatioCuris, we have done and signed up an MOU with the Swecare, and Shampa has already brought out what is the Swecare and how we wish to do it. Now I have Dr. Vijay Agrawal, who is a good friend of mine, very senior physician. He is the president of Consortium of Accredited Healthcare Organization, because every country, every hospital in India is not yet accredited, and most of them are non-accredited. So he is having a prestigious organization he is heading. He is in fact a founder of that organization. So the advisor of a Max Healthcare group of a hospital and quality and excellence, and advisor to Global Association of Physicians. He is a person of a great virtue. So I thought, when all this you want to bring it to India, Swedish company may like to know how India setup is there, so that they know what are the things they can bring it, because there are many issues. So I thought he's the best person heading those hospitals, and I now request Dr. Vijay Agrawal to moderate the whole session And in the last, I will again come to conclude and thank, etc. That means there would be, he will be sensitizing, then there are two speakers who will be coming from who is speaking from Sweden. There will be some question answers from both the sides, from the viewers, and ultimately, this is not the end. This is the first of a series. Probably based on the demand, we will have number of such series of webinars, so that some of them who are coming to India, maybe for a conference on 5th, 6th October or later, their well was what India is and how Sweden can work. Over to Dr. Vijay.
Good afternoon, friends from India, and good morning to friends from Sweden. First of all, thank you very much, Dr. V.K. Singh, for giving me this opportunity to do this interaction on behalf of myself and CAHO, which is the Consortium of Accredited Healthcare Organizations. So thank you very much. I think what I would like to first of all point out that a perfect healthcare model has eluded most countries, including the developed ones. India, which is more of a continent rather than a country, has its own unique challenges. However, we have a lot to learn from developed nations like Sweden. The caveat is that these people from the developed country need to know that India is got the second largest population. We are the 7th largest country in the world. We have at the moment 50% people who are below 25 years of age, and still we have a good number of people who are now aging, and significant number of people who are now coming into the geriatric age group also. We have 780 dialects spoken, 86 scripts are being used, and still we have the second largest pool of scientists and engineers. We have a huge amount of tele-density. We have surpassed most countries in the use of smartphones. We have good amount of internet users, and still our poverty rates are pretty high. So we are a mix of contemporary and traditional world. The idea is that whatever we may do, I do not think that it can ever be applicable to our whole country. Most important thing for the country is to find affordable healthcare solutions from whichever part of the world we can try to learn. If I look at the key healthcare challenges that we have, then my take would be that one of the most important things we have is the inaccessibility. About 700 million Indians which are in the rural areas, they do not have access to the healthcare. Now, of course, recently with the announcement of the Ayushman Bharat and the NHPS schemes, there will be some distance that we will travel to address this issue. But this problem is not going to be as easily solved by such announcements, for the simple reason that we have lack of skilled manpower in the country. Now, the skewed doctor-patient ratio, which is seen as in our country as 1:1700 as compared to 1:1000 in the developed countries, this is again very misleading, because I think for the metro cities, for the bigger cities, this ratio must be again closer to 1:1000, while the ratio in the rural areas and the far off areas, will be more than 1:3,000, 4,000, whatever. We do not have, number one, data to, in fact, do not have mapping of this kind of thing to take it in a very structured way forward. We have vast variations in our literacy, and therefore our approach to reach people in terms of their health awareness, in terms of the strategies which are to be used, will have to be multi-pronged. No one approach can fulfill all the needs. Our system of medical record keeping is still traditional. It is a paper-based system because most people feel it is very reliable. The fear of technology failing is still very high. And on top of that, there is all this, I would say, the Western system of the, I would say, my data being secure or not, or should my healthcare data be available for in the common pool has been created as a big fear. And without that data, I think we cannot create structured solutions. We do not have at the moment national standards to follow. I mean, the standards are there, a lot of standards are there on the paper in terms of compliance to the EMR and EHR, but then there is a reluctance of the medical and the nursing level people and their attitude for them to change. Then, and the third big challenge is that now, besides the usual problems of the infections, besides the problems like malaria, dengue, and of course tuberculosis taking a huge toll of life in our country, we have a rise in the chronic and the lifestyle-based conditions. And this is now becoming a huge, huge problem, especially in the metro towns. So absence of a system that seeks to manage the chronic conditions is causing a great problem. So with this, what we feel is that help which we can come from developed nations like Sweden will be a great, great help. And we are looking forward to, I would say, solutions which are disruptive, which can bring about change for the positive for our healthcare. So with this, I will like to introduce the next speaker. The first speaker here is Cecilia Edstrom. She, as the Chief Financial Officer at Bactiguard, she is a member of the executive management team and responsible for business development. Over the past 3 years, she has managed the company's expansion in the Indian market. So over to Cecilia Edstrom.
Thank you very much, Dr. Agarwal, and also to Dr. Singh for making it possible for me to participate in this. Can you hear me and can you see my screen? Hello? Hello? Hello?
Yes, we hear you.
They've seen, the organizers seem to have gone off line.
And I cannot see your screen, but I can hear you. And I hope others can as well, but I don't know where the organizers are. Dr. VK Singh?
Yes, we can hear you and can't see her.
Okay, well, I'll try to put myself on the screen. Can you see my screen?
Yes, one second.
If you can't see my screen, there's a fallback option where you can share my slides.
Cecilia, can you try it again, sharing your screen, please?
Excuse me, could you repeat that?
Please sharing your screen, ma'am. Yes.
Okay. Well, I think it's easier if you show my slides. It's the fallback option. It doesn't seem to be working.
Okay, no problem. We'll share your screen from here.
Okay, very good. Well, in the meantime, whilst you're doing that, I'm very delighted to be on this webinar, since I've been frequently traveling to India over the past 3 years, which is the period in which our products have been available in the Indian market. And in fact, in early September, I will be going to both Mumbai and Delhi to talk about infection prevention, which is what I'm about to talk to you about here today. So if we go to the first slide, which is a copy of The Economist from I believe it's a May or June edition from 2014, which is showing the fact that doctors are increasingly facing antibiotic resistance, which means that they cannot treat infections which they have been able to treat since Fleming introduced antibiotics in the 1940s. And this is becoming an increasing problem to treat very common infections like pneumonia, appendicitis, urinary tract infections, and etc. We can go to the next slide, which is showing antimicrobial resistance across the world. Today, about 700,000 people are expected to die from infections which cannot be treated by infections. And by 2050, if we don't change this trend, as many as 10 million people may be at risk from dying of infections which cannot be treated. This is more than kills cancer every year globally. And the countries which are most exposed to this are India and China in Asia because of the high consumption of antibiotics. We move to the next slide. There is statistics from the WHO that about 1 in every 10 patients are affected by healthcare associations worldwide. But what they also say is that a large proportion of these infections are possible to avoid if you introduce effective preventive measures. Moving on to the next slide, which is showing the status in India, although statistics is very difficult to come across, you could see that in the Western world, healthcare-associated infections is the 3rd highest cause of death, following cardiovascular disease and cancer. In India, the statistics are hard to come by, but we know that it's the single largest antibiotics-consuming country in the world, and that at least 2 million people or patients are affected by hospital-acquired infections every year, most of those in the ICUs. And also many parents are experiencing that their babies die in prenatal and natal care from organisms which are resistant to normal antibiotics. Moving on to the next slides, you could see what the challenge is. Well, according to the WHO, preventing healthcare-associated infections has never been more important than it is today because of the antibiotic resistance. So infection prevention and control, if you introduce those actions, they can save millions of lives every year. Moving on to the next slide, this is what Bactiguard is all about. Our vision is that we will be able, at some point in the future, be able to eliminate healthcare-associated infections to, most importantly, save the lives of patients, but also free up capacity in the hospital. And as Dr. Agarwal said, accessibility to healthcare is of paramount importance. If we can free up bed capacity, then more patients can get care. And if we reduce the number of infections, we can also reduce the use of antibiotics and prevent the spread of multi-resistant bacteria. We move on to slide number 8. You could see that the most common areas of the body where hospital-acquired infections occur are the urinary tract, the bloodstream, and the respiratory tract. And you could also see that the causes of sepsis, which is effectively the body's response to an infection which damages its own tissue and organs, is the urinary tract infections, pneumonia, and the use of catheters. And that's why Bactiguard has developed products that prevent infections in those areas of the body, the urinary tract, the respiratory tract, and the bloodstream. Moving on to page number 9, what actually causes infections in the body related to catheters? Well, by bacteria entering through the medical device and adhering to the surface of the device and creating a biofilm, which can then be dispersed into the body and create infections. What Bactiguard is that we provide a surface to medical devices that prevents bacteria from adhering and creating biofilm. So you could see at the bottom of the page through an electron microscope on the left side is an uncoated surface, and to the right a coated surface where much fewer bacteria adhere. Moving on to the next slide, just a few words on the technology, what it does and what it doesn't do. It consists of 3 noble metals, very thin layer, which doesn't alter the characteristics of the underlying device. But when these devices are introduced into the body, the different electropotentials of the metals create a microcurrent. So it becomes uncomfortable for the bacteria to stick to the surface, reproduce, and create biofilm. It's not releasing, so therefore it's not harmful for good bacteria or the patient's tissue. So you could say it's both effective and safe. So where should it be applied? If we move on to the next slide, you could see that on average, if the 1 in every 10 patients gets an infection in a hospital, 1 in every 1/3 of patients, or maybe as many as 60 to 90% of the patients in an ICU will acquire an infection. And these patients are already exposed because they're seriously ill and immunosuppressed. So the mortality rates are very high, between 25 to 50% if you acquire an infection in the ICU. It's also very costly for the hospitals to treat these infections, and it increases the average length of stay by almost a month. So therefore it reduces capacity. So what's the price of these catheter? Is it very costly? Well, I think you should, if we move to the next slide, look at the total cost of treatment. And this is where innovation has an uphill struggle, that innovative products may be a little bit more expensive than standard products. But if you look at the total cost of care, it reduces it dramatically because of the shorter length of stay, because of that you don't have to introduce additional therapies, and therefore can actually reduce your costs in total. Actually, I skipped one slide. If we can go back to one, to look at why Bactiguard should be standard in every ICU. It's because patients are exposed in all 3 areas, bloodstream, respiratory tract, and urinary tract. And we have products that actually address the problems in each area. They are all approved and available in India since the beginning of this year. And we have access to several of the main hospitals. Currently, we are some of the big ones where we are present at are Medanta and RML in Delhi and Sri Gangaram also in Delhi. We are concluding clinical trials, including 1,000 patients at 5 different locations across India, which we will be publishing in the autumn with very good results. So I think we will be able to meet several of you when we visit India later this year and conduct seminars across the country. And just to conclude, on the last slide, page 14, preventing infections has never been more important than it is today because of the rising antimicrobial resistance. So in order to protect the patients, we need to reduce infections. The problem should be addressed at the source. Prevention, hygiene routines, training of staff, and the use of innovative solutions. And in order to be able to introduce innovative and preventive actions, one needs to focus on the total cost of treatment, but also introduce quality criteria in tenders and direct purchases, because if there's only a competition on price, innovative technologies will never make it. And also develop new guidelines for hospital staff, clinicians, on how to introduce hygiene guidelines, how to use new technology, and how to engage in continuous development. And last but not least, use the clinical evidence that is available from other markets and data, clinical data as a reference when you introduce new technology. With that, I would like to hand back to the moderator. Thank you.
Thank you. Thank you, Cecilia. And for the wonderful presentation, I think to highlight the importance of hospital-associated infections and the rising antimicrobial resistance in a big way. We'll be very happy to take any questions from the participants. And even while the next speaker is on, you can send your questions. So maybe even at the end of if there is any question right away, otherwise what we'll do is we'll go on with the next speaker, and please keep sending your questions so that we'll take it at the end of these 2 speakers. Next speaker is Annette Kumilian, and Annette is the Chief Operating Officer at Daverum. She is a member of the executive team of the group and is also on the board of directors, operational. So over to Annette.
Hello, this is Annette Kumlin. I hope you can hear me. Just to give you a short description of who I am. I work as a COO today since 2014 in Daverum, and I joined Daverum in 2007 as the CFO. My prior career path was outside of the healthcare industry. It was actually in the process industry with specialty steels, specialty chemicals, and also consumer capital goods. I posted the presentation so you can follow along also to give you a little bit of a red thread through my speech. If you look at the agenda, it's a bit about setting the scene, what's going on in the healthcare, and I think Dr. Agarwal, as you also said, there is an issue when it comes to the tsunami of chronic patients coming in. It's a different profile. Looking at from the way that we are addressing it, it's a bit what gets measured gets done, which is an old anthem, but also gets improved. And then also understanding the future from a patient point of view in order to deliver a better care, which is also affordable care from a national point of view. If you look at what's going on in the world today, there is a demand on the new system. If you look at most countries, they have set up their healthcare system based on acute illnesses because that's where we come from. So you get sick, you go into the hospital, you get cured, and you leave. But if you look at what's going on today with the lifestyle and the chronic diseases where patients are multiple diseases, it is not any longer going into the hospital, getting cured, and then you're done. It's actually so that you will return to your healthcare practitioners regularly. and often and different healthcare practitioners as well. And navigating as a chronic patient in a system which is set up for acute patients is not easy. And this creates a new demand on the system. And not only the system per se, but also on the healthcare professionals. When you look at changes, I mean, you have the incremental innovation and also giant leaps. Healthcare has never really been exposed to leap innovation as you have seen in other types of industries. And if you look back to when we went to the moon, as Neil Armstrong said, it's a small step for man, but a big step for mankind. There was huge activities going on to put the man on the moon, and it was a big change for us. If you look at an analogy into the healthcare industry, is that a lot of the things that we're doing now in the healthcare industry and that we need to address is a big leap for us. But maybe there's also some benchmarks and some best practices to be gained outside of this industry that has already been done in other settings. If you look at the industry that I am in, we're in the chronic kidney disease activity. We're dealing with renal patients that have lost their kidney functions. If you look at it today, there is around 7 billion people in the world. 10% of them, they have CKD. So we're talking about 700 million people, which is quite a big problem. There are 5 stages, and it's when you get into the 5th stage, CKD 5, that's when you lose your kidney function and you actually need a replacement therapy. The best option is obviously to get a transplant, but not all patients can handle this type of surgery, and there are not enough organs either. The second option is really to go for dialysis, and there are different methods. You can either go to an in-clinic hemodialysis, which means you go 3 times a week to a center and you get your blood cleaned. Or you could actually do home therapy, which means that that requires more or less more mobile and more agile patients to be able to do that. And also when you look at a renal patient, it's not only that they lost their kidney functions, there's a lot of services around it that needs to be addressed, like for instance, vascular access. And also you have transportation, patients need to travel. And also when you look at the renal patient per se, there are a lot of other comorbidities related to it. It is a growing cost. I'm not going to get into the exact numbers, but basically, if you look at it, CKD is about 10% of the population. When you look into the Medicare cost, talking about the US setting, where there's a lot of good data to watch, basically, the Medicare cost is about 30%. So you can see that the disproportional cost versus the number of people that are sick. And also when you look at one of the causes for renal failure is actually diabetes. And you all know the tsunami when it comes to diabetic patients across the globe. Another impact also on, or why you would lose your renal function is actually high blood pressure. And that is about 30% of the patients that come to us that have this problem. So with this type of numbers and you know what's going on in the lifestyle activities, you also know that this causes that tsunami of patients going forward. And then again, an acute setting system does not really work for the chronic patients. So how are we address this and how are we working? Well, basically, if you look at it, to get high quality care, there are 6 activities that we are focusing on. One of them is obviously how our operations look like. It's also looking at standard care, setting protocols. It's also about monitoring and making sure that we follow up and use this as a continuous improvement cycle. It's about incentives for quality. It's about also making sure to follow up with auditing programs to learn what gaps we have and where we can improve further. And then obviously also making sure that we have a competent and motivated staff. This picture just shows a bit of our different centers that we have around the world. DAVIARM exists in 20 countries, and as you can understand, we need to adapt ourselves into the country-specific settings and also local regulations. And that makes our clinics look a little bit different. At the end of the day, it's about making sure that the patient gets treated in a way that fits him or her and address his or her need in those settings. The other thing is working with clear benchmark and protocols and making sure that those protocols are being underlined with scientific, with research that can improve them, and also making sure then that the collective knowledge that we have within our company actually is then being put into action through those type of protocols and standard way of working. This just shows a bit about how we work with what gets measured gets done. For the past 20 years or so, we actually monitored the key factors of making sure that the therapy that we do actually is effective. And as you can see, also year on year, there is an improvement activity because of the learning curve that we are working on, and how we're addressing it with the different systems, the protocols, and also how people address in this continuous improvement process. That type of thing is, as I said, then also followed up with the auditing program, which is basically making sure that all our clinics are being followed up on a regular basis to make sure that they are following the settings that we have decided upon. We also work a lot with our staff to make sure that they're competent and motivated. We also work with our patients. So what we do is that we measure our patient and employee satisfaction on a regular basis. And with that, those comments and those intel that we get from these type of satisfaction research, we put up thoroughly action programs that we deliver on and move. And that's also where you can see that the improvement is coming into spec. So what about our patients though? Well, as I said, that our patients don't only have renal failure, they also have other illnesses, like they have diabetes, like they have issues with hypertension. So for us, it's very important to be able to make sure that we can actually work with the patients more holistically, and also make sure that in those countries where we're allowed to actually work with preventive care. Because at the end of the day, if you can prevent or delay a patient going into dialysis, that means a lot for quality of life and also from a health economics point of view. So if we look at challenges and solutions, it's a triangle activity. At the end of the day, it's about understanding our patients. We know that there is a tsunami because there is an older patient base. There's also more chronic diseases caused by the lifestyle that we are living in today. And when you look at it, making sure then also that we have the staff. And as you know, there is in most countries also a shortage of staff, and this is then we need to focus on how do we work with regulations, how do we work with also skill mix activities to understand how we can make sure that we can deliver the patient care that we are supposed to do. And then obviously at the end of the day, there is also a cost challenge going into the demographic side, where again, as Dr. Agva said also, it's about making sure that we can work with our patients from a holistic and integrated point of view and work a lot with preventive activities. So that's all from me. Thank you very much for your time, and I look forward to questions later on.
Yes, so thank you for giving again a very nice talk on the chronic kidney disease, which is again a very, very important part of our disease spectrum in our country also. So we'll now look at some of the questions that have been posed. In fact, the first question that I can see is for me, that's by Shampa asking, Dr. Agarwal, what in the accreditation process leads to an improvement in quality, if indeed that is the case? Well, all I can say is that the main benefit of the accreditation is to move away from our individual ways of functioning to being process driven. And from individual to a teamwork culture is what we are trying to work out, that healthcare delivery, which was only between a doctor and a patient, has now become a multi-stakeholder delivery, and therefore all the people in the hospitals are equally important. So we are focusing on issues which were swept under the carpet, things like fire safety, or let's say hazardous material risk, so many things which the doctors were really not concentrating. we are now concentrating as a part of the accreditation. So there is some improvement. However, I would say that we are just scratching the surface as far as the quality is concerned. For two reasons, we have really not ventured into monitoring the clinical quality, which is the real thing in terms of how do we see that we do not make a delay in diagnosis, how do we really make sure that there are appropriate investigations that are done. So many things are still to be thought about, covered. I would say I heard something very nice recently in Canada, that mental health issues of the people who are working and of the institution was a part of the accreditation there. And the other thing is that if we do accreditation merely for the stamp of accreditation, then we are really not bringing about any quality improvement. So I think accreditation is a good way to start improving things. Next question by Shampa is to Cecilia. How long is the training process for the use of your products, and is that included in the price?
Well, our products are used in the same manner as other basic products. But again, what we do when we introduce our products into a new hospital is that we provide training for the staff, which can be in the form of a seminar, individual training of the trainers, because we do believe we also provide online training by way of videos and everything, because we think that the total package is important so that you can not only introduce new products, but also improve your processes and your way of working. And yes, it is included in the price.
So for Annette, do you set up centers within the hospitals too?
Yes, we have various settings.
Have you used it in Delhi? I'm sure that's to Cecilia.
Sorry, I didn't hear it. I was disconnected briefly.
I want to understand that some Bactiguard products were used in some Delhi hospitals.
Yes, RML and Sri Gangaram, and I'm actually visiting Max at the middle of this month. It's also used at Medanta, so yes, it is used in several Delhi hospitals.
So do we have data to show the impact of that use, is what the question is.
Yes, it's interesting that you should ask that question. We've just finalized the inclusion of patients in a study in India, including 1,000 patients at 5 different sites or 5 different cities across India with very favorable results. So in September, I will be happy to share that information. But we also have data and clinical evidence from several other markets that our use of our catheters will reduce infection rates by somewhere between 35 and 60–70%.
Okay. So we'll be very interested, of course, in I think getting some more data, and these hospitals should share their experience. What is the cost of the Bactiguard product? Is a question by Prabhavati Reddy.
Well, it depends on the product. So I don't know exactly the retail price in India off the top of my head, but it is more expensive than standard products. But so far, the prices which have been introduced in India have not met resistance because of the additional costs when you're not providing preventive action. So it has not been a problem so far.
Okay, so from where can someone get the idea about the cost, let us say, of these participants who have learned? I'm sure they may be, some of them may be eager to use. So whom should they contact and find out about the pricing situation?
They should contact our distributors, which is Neon Laboratories or Hospro for the west, north, and east of India, and INCARP for the south. but I can also put them in contact with our Director of Indian Operation, Manish Agarwal. There are contact details on the final slide of my presentation that I'd be happy for you to share with the audience.
Okay,
They can
so
also contact me, so I can put them in contact with them, with the right people.
Okay. Then Shampa had, of course, another thing as a part of TANET as to what is your biggest obstacle for training the staff or for the trained staff?
Was that a question for me as well?
Yeah, that's to Annette,
Okay.
actually. That because she was asked that do you set up centers within the hospitals and what is your biggest obstacle? Trained staff, is that your obstacle?
So yes, we do set up clinics inside of hospitals as well, and we have various ways of. We have actually different ways when it comes to clinics, depending on the country setting. Everything from management contracts, obviously, to our own clinics. So that's the basic modus operandi that we have. When it comes to training, this is coming back then again to, as I said, understanding what are key when it comes to treating a dialysis patients, making sure that you have protocols around it. And then we do have developed training programs for our staff. We have actually set up a DAVRM Academy where we have programs for our nurses, for our doctors, as well as for our clinic managers and also for management positions in order for the different categories to understand how to work. But yes, we do have training programs for our nurses and clinic staff.
Okay, thank you so much. I think we have a couple of questions which we will be able to probably disseminate to the participants directly, as we are now running short of time. I am handing it over to General V.K. Singh for his concluding remarks.
Thank you very much, Dr. Agarwal, for your time and sharing everything, whatever participants and speaker wished to know. I'm really thankful to the JOSA, Shampa, speakers and participants and my organizing team. I definitely agree that probably we should have had a little more time because there are some questions are still there which are not answered because of the paucity of time since we have to close at 4. Well, I don't mind if you send these questions and you still look for the answer, we can pass it on to the respective speaker or a moderator. And just those who wanted to note down, my email is vksingh@innovatiocurist.com, and probably somebody will flash it out to you. That is for those who wanted more information. We'll get in touch to the speaker or a moderator and pass it on to you. I'm really thankful once again to everyone for such interest. This has been first such webinar. And of course, we have been having webinar every alternate month on different issues. But this is what we decided. Why not have talk people who are from the developed countries if they have some better products. So this will be passed on to you, email already done, so that in case you have further anything. Next webinar, as usual, we will give the information to everyone so that we can have that. Thank you very much for everyone for the thing. Thank you. Thank you very much.